Witam Państwa serdecznie. Nazywam się Mateusz Gola i mam
Good
przyjemność
afternoon, ladies and gentlemen. My name is
koordynować
Mateusz
tą
Gola,
sesję
and I'm
na
going to
koniec
be the
dzisiejszego dnia.
moderator of the last session today.
Bardzo dziękuję za
Hello, Mateusz. I
zaproszenie
wanted to
na
introduce you.
konferencję i przykro, że
I
nie
wanted
możemy być osobiście z
to
Państwem,
thank you for inviting me
ale
to the
mamy
conference. I'm sorry I
fantastycznych
cannot join you in
speakerów
person,
dzisiaj i mam
but we
nadzieję,
have
że
wonderful
Państwo
speakers joining us
będziecie
remotely.
zadowoleni z tej
So
sesji.
I
Dużo
do
ciekawych
hope that
rzeczy
you are going to
na
be
niej pojawi.
satisfied with the last session and that you're
Pozwolę sobie
gonna listen
przedstawić na
to
początek
really
naszych
interesting
speakerów. Przełączę
presentations.
się
I wanted to introduce our
na angielski,
speakers
tak żeby każdy
initially.
mógł
I'm
zrozumieć.
gonna do that in English.
I później przejdziemy do prezentacji. Więc I will welcome all speakers in English, and then we'll switch to English with the presentations. So first, we will hear the presentation of Dr. Shane Krause, who is a professor at the University of Nevada, Las Vegas in the United States. And he's also a clinical psychologist working with people with behavioral addiction, not only compulsive sexual behaviors, but also gambling behavior. He co-authored or authored over 140 research manuscripts, and he's also a member of World Health Organization working dedicated to compulsive sexual behavior disorder and the new clinical entity which will be included in the ICD-11. After Shane, we will hear a presentation of Dr. Beata Bede, who is currently a postdoc at the University of Montreal. She authored over 80 scientific publications, most of them dedicated to compulsive sexual behavior disorder. And she also created a screening test for compulsive sexual disorder, which screens for all the symptoms included in ICD-11. And this screening test was already adapted to over 20 languages. She is also a coordinator of a huge international study on human sexual behaviors, which is conducted in over 50 countries around the world. After Beata, you will be able to hear Ewelina Kowalewska, who is there in person in Warsaw, and Dr. Kowalewska works in the Centrum Medyczne Kształcenia Podyplomowego in Warsaw. She graduated from University of SWPS, and she's a researcher and also has a background in sexuology. And since 2014, she's one of the key members of the Polish group Hyperseksualność.pl. She authored and co-authored over 20 research manuscripts, and she's one of the pioneers in studies of compulsive sexual behavior disorder among women and non-heterosexual populations. After Ewelina, we will hear a presentation of Dr. Joshua Grubbs, and he is a professor at Bowling Green State University in the United States. He also has a background in clinical psychology. He authored over 100 research manuscripts, and he's an author of the model of moral incongruence in compulsive sexual behavior, which is a very important part of knowledge about compulsive sexual behavior disorder and self-perceived sex addiction, pornography addiction, and results of his studies were also included in the criteria of compulsive sexual behavior disorder published by World Health Organization in ICD-11. So we can learn a little bit more about this model from him. And at the end, I will present myself, and each presentation will take approximately 12 to 15 minutes, maybe a little bit longer with translation. And each of them will present the current state of knowledge, of the knowledge from the field of expertise of each of our experts. And also I asked every one of us to present three most important questions for the future studies. Those things which we still don't know about compulsive sexual behavior disorder, but we would need to learn it in the near future to understand this disorder better and to be able to help patients with compulsive sexual behavior disorder more effectively. So without further overdue, let's move to the first presentation. Unfortunately, yesterday we received information from Shane Kraus that due to his personal emergency, he won't be able to present, but he sent his slides, so I will present for him. And let's start. Okay. So I already introduced Shane, and this presentation will talk briefly about the compulsive sexual behavior disorder and three most important questions according to Shane, which we will need to answer in the near future. So next slide, please. So the first construct related to CSBD. CSBD is a compulsive sexual behavior disorder. We'll use this abbreviation over multiple presentations today. Was sexual addiction, presented by Patrick Kearns in 1983. And basically this concept was based on the analogy to addiction, but it wasn't included in any major classification of disorder due to the lack of systematic research on that. Then the next was out of control sexual behavior, which is much more generalized. And then in 2010, Martin Kafka presented hypersexual disorder. And this was the first attempt to enter into the major classification of disorders. In this case, it was DSM-5. It's a classification of American Psychiatric Association. But due to the lack of sufficient data on this entity, it wasn't included in DSM-5. And then after that, we all started working on providing more data to World Health Organization, which was considering to include something similar in ICD-11. And finally, in 2019, World Health Organization announced the inclusion of compulsive sexual behavior disorder in the upcoming ICD-11. It will be officially released and published starting from January 1st, 2022, so in 1 month and 1 week. There are some differences between hypersexual disorder and CSBD. One main difference is related to the lack of the symptoms related to mood regulation and stress regulation. We don't have it in CSBD diagnosis. We had it previously in hypersexual disorder. Another important difference is related to inclusion of the criteria related to moral incongruence. In CSBD, we didn't have it in hypersexual disorder. And Josh will tell us about it a little bit more. And one of the subtype of CSBD is problematic pornography use, which have been also extensively studied because majority of people seeking treatment for CSBD present problems specifically with problematic pornography use. Okay, next slide. So diagnostic criteria of CSBD, as World Health Organization describe it, are quite clear. And basically we can say that someone have a problem with compulsive sexual behaviors when this person is neglecting health and personal care due to the sexual activity or other important responsibilities, work responsibilities, school related duties, and so on. If this person presents numerous unsuccessful efforts to control his or her behavior and continues this behavior despite adverse consequences, and finally continues this behavior despite lack of satisfying sexual behavior or even negative feelings related to the behavior. Next slide. There are two additional criteria. One is related to time. So this pattern of compulsive sexual behavior needs to last at least 6 months. So it cannot be, very short. And it cannot be that this dissatisfaction or a negative mood around the behavior cannot be related only to moral judgments or disapproval about one's sexual impulses, urges, or behaviors. Next slide, please. Okay, so here we had a few very important issues related to the boundaries between normal sexual behaviors and something which we can call disorder, as in case of compulsive sexual behavior disorder. So first of all, we cannot recognize a disorder based on the frequency of the behavior. So this is important, that this behavior has to impair someone's life, and there is impaired control over sexual behavior. We cannot also recognize a disorder if it's related only to the moral disapproval or judgment around one's sexual behavior. So we don't call it disorder if it's due to the moral disapproval. Yeah? And finally, we can't recognize a disorder if it lasts only for the brief periods of time. So sometimes people can present, exaggerated sexual behaviors as a response for medication, or when they are under the influence of some substances, for example, stimulants. And this lasts for the brief period of time, not more than 6 months, so we don't recognize it as a disorder. Next slide, please. We also don't recognize compulsive sexual behavior disorder if we can explain this disorder better by paraphilic disorder. So if someone has very specific sexual preferences and we can recognize paraphilia, we don't recognize CSBD. We don't recognize CSBD if we can diagnose manic or hypomanic episodes. We know that in such episodes, people have higher sexual drive. And we don't recognize CSBD when we see dementia syndrome, so some neurological conditions which may impair a control over one's sexual behavior. And finally, we don't recognize CSBD if those behaviors emerge as a result of misuse of illicit substances, which I already mentioned at the previous slide. Next slide, please. Okay, so what do we know about prevalence of CSBD? We know only estimations so far, and according to some studies, it's less than 3% based on Martin studies, which were related to hypersexual disorder criteria. Among people who use substances, it's higher. It can be over 25%. On the bigger samples, we know only how it looks like. How does the self-diagnosed compulsive sexual behavior looks like, but it doesn't necessarily mean that it meets the criteria of CSBD as presented by World Health Organization. And here estimates tells us it's something around 7 to 11% of males and about 3% of women. But as I mentioned, we still don't know how many of those people not only self-diagnose themselves as having problem, but how many of them really meet the criteria of CSBD. Next slide, please. It's very common that people who are seeking treatment for compulsive masturbation or pornography use, they diagnose it as problematic. And we also see that those two behaviors are really the most common behaviors among people who meet criteria of CSBD. It's even up to 70 to 80% of people who meet those criteria. But there are also some other behaviors which are very important, like frequent casual anonymous sexual encounters, or having multiple sexual partners at the same time, or using paid sexual services. And so there's like huge variety of behaviors within CSBD category. And next slide, please. The main risk factors related with CSBD are early onset of initiation of sexual behaviors, history of sexually transmitted infections, substance use, there is some comorbidity here, depression, anxiety, or some suicidal attempts, and also comorbidity with other impulsive behaviors and other behavioral addictions. Next slide, please. And those comorbidities are pretty common, and there's also very often people diagnose them rather than CSBD. And here very often it's comorbid with OCD, alcohol use, major depression disorder, dysregulation of emotion, PTSD, some risk of suicide, depression, anxiety disorders, or other substance use disorder or impulse control disorders. Next slide, please. So according to Shane Krause, the next steps and big research questions is to compare the diagnostic criteria of CSBD and hypersexual disorder and other addictive behaviors, and see what are the similarities with the symptom cluster and examine them, and also check for the differences, as there were differences in those two diagnoses. The second question is what is the prevalence of CSBD in general population? So how many of clinical and non-clinical, how many people in clinical and non-clinical population really meet the criteria of CSBD? So for this, we need national representative samples, and such studies also would need to be longitudinal, so we can see how the severity is changing. And the third big question is to check how does the prevalence of CSBD looks among women, with not only and in population which are not only white males in developed countries, but also in population with low and high income countries, youths, LGBT population, and among older adults, and all other groups which we didn't study in our research so far. So those are the three big questions. Okay, next slide. So this is the closing slide for Shane Krause, and now we will move to the presentation of Beat, who will tell us a little bit more about the diagnosis and those big studies on the representative samples around the world. So Beata, the floor is yours.
Thank you. Can you see my slides? Okay. Hello everyone. In the following, I would like to talk a little bit about how we are planning to lay the foundations for a high-quality assessment of compulsive sexual behaviors in diverse populations, what are we doing now, and what are the most important next steps for the field. Next, please. Next, please. I will start with a little introduction of the current state of the field, what are the main limitations and shortcomings of previous studies, and then we will answer and talk about 3 research questions. Next, please. 3 clicks, please. So here we will talk about how... Thank you. So here we will talk about how to assess compulsive sexual behaviors in diverse populations, and then we will zoom in a little bit and talk about how to identify potential risk populations who might develop compulsive sexual behaviors. And lastly, we will talk about how to identify potential risk and protective factors that might be related to compulsive sexual behaviors. And in the International Sex Survey, we aim to answer all these questions, or at least contribute to the answers to all these questions. So I will show you what are we doing right now in the framework of the International Psych Survey, and I will summarize everything that we are talking about at the end of the presentation. Next, please. Next, please. And I think we can skip this slide as we have heard all the diagnostic criteria and prevalence of compulsive sexual behaviors. So we can go to the next step, which is about what we know so far about compulsive sexual behaviors. So based on the findings of a recent systematic review, we can see there's a quite huge increase in compulsive sexual behaviors research. As you can see, next please, more than 300 studies were conducted about compulsive sexual behaviors. And what we can say is that, oh, sorry, I don't know what's going on. Okay, great. This would be great. So, what we know so far from these 400 studies is that there are several limitations of previous studies, and actually our knowledge is quite limited. Here you can see that there are several shortcomings of previous studies, including the use of small heterogeneous samples, such as male college students who are mostly heterosexual. Most studies did not use well-validated scales or questionnaires to assess compulsive sexual behavior, which means that we cannot be sure whether they really assessed compulsive sexual behavior or whether they assessed some other related constructs, such as high sexual desire, without any problems. Moreover, what we can also see is that most studies were conducted by independent laboratories, and we cannot really see large-scale collaborations between different laboratories and countries. So our knowledge, cross-sectional knowledge, cross-cultural knowledge about compulsive sexual behaviors is quite limited. And all these things and other factors led to the fact that we don't really have rigorous knowledge about the potential efficacy of treatment for compulsive sexual behaviors. So what we should do in our studies is that we should use rigorous methodological designs with large diverse samples, including sexual and gender diverse individuals, culturally and ethnically diverse individuals, and we should use well-validated, high-quality assessment tools in all studies to be able to compare the findings of different studies. Moreover, we should use different theoretical models for our research, which might lead to the development of different models of CSBD, which are based on scientific knowledge and empirical findings, which is currently missing from the field. And all these things might lead to the examination of different treatment methods for compulsive sexual behavior disorder using randomized control trials, providing knowledge about the efficacy of different treatment options. In the International Sex Survey, we will focus on everything except for the randomized control trial part. So next, please. Next, please. If we zoom in to the results of previous studies and we think about the most important shortcomings of previous studies, what we can see that one of the main issues is that previous studies did not use well-validated and psychometrically strong assessment tools to measure the levels of compulsive sexual behaviors, and most studies use different assessment tools. So we can compare the results of previous studies and we can generalize knowledge that we can derive from previous studies. Fortunately, with the hypersexual disorder diagnosis, the assessment started to converge, and with the CSBD diagnosis, we can see an even greater convergence of the assessment of compulsive sexual behaviors. But still, there's no gold standard assessment for CSBD. And this is quite a huge problem because a high quality assessment is needed for any further research. So this is a quite important and essential first step in the field right now. This is why we decided with my colleagues that we should develop a scale that can assess CSBD based on the current ICD-11 diagnostic guidelines, and this is the CSBD-19. We developed this scale in an international setting with more than 9,000 participants, and it seems that the scale works really well, but we knew that this is just the first step, and now we need to examine this scale in different cultures and different countries. So this is one of the aims of the ISS, to examine the psychometric properties of the CSBD-19 and several other sexuality-related measures in international settings. Next, please. And this will help us to answer the second and third question of my presentation: who might develop compulsive sexual behaviors and why? Next, please. So, as you could see, more than 400 studies were conducted, so you might think that we have a quite good knowledge of who might develop compulsive sexual behaviors and why. But if we again zoom in and check the results of the studies, what we can see is that most studies were quite weird. Next, please. And when I say weird, it's not about the results of the studies or the methodology, but it's mostly about the samples. Most studies were conducted among white, educated, industrialized, rich, and democratic samples and countries, so we can't really generalize the findings to the whole world. This is why we decided, in line with recent calls and findings of the field, that we should examine risk populations and potential risk and protective factors of CSBD in large, diverse samples all over the world. So the second aim of the ISS is to identify people who may develop compulsive sexual behaviors or who have self-reported compulsive sexual behaviors, and examine which factors, risk factors, may contribute to these higher levels of compulsive sexual behaviors, or which factors may play a protective role in the development of compulsive sexual behaviors. Next, please. Next, please. So, just to summarize, in the International Sex Survey, we are planning to validate and provide publicly available screening tools for different sexual behaviors, including compulsive sexual behavior. We want to identify populations that might be at high risk of developing maladaptive sexual behaviors, and we want to study mechanisms that may underlie the development of different problematic sexual behaviors. Next, please. And in the ISS, we use theory-based innovative approaches and high-quality measures and statistical approaches. In the ISS, we have a great team of investigators and collaborators. The principal and co-investigators planned the study and prepared all materials, and collaborators from the 45 countries translated the survey battery and collect data. Next, please. Currently, as I mentioned, we have 45 countries from 5 continents. Next, please. And here I don't want to bore you with the details, but we started to plan the study last October, and we started data collection just 2 or 3 weeks ago, and we actually already have more than 17 or 18,000 participants, which is great. We are planning to collect a huge sample, which means that we would need 2,000 participants from each country, and then we will conduct sophisticated statistical analysis to answer all the questions I just mentioned. Next, please. Next, please. So, with the International Sex Survey, we will have a better understanding of a wide range of sexual behaviors, including compulsive sexual behavior, and based on the findings of diverse populations, which is quite important because we cannot generalize findings from weird samples, white educated, industrialized, rich, and democratic countries. Moreover, we will provide well-validated, publicly available screening tools for researchers, healthcare practitioners, which may help eliminating major issues in the field, such as the use of low-quality assessment tools. And this way, we might develop a high-quality, unified assessment of compulsive sexual behaviors all over the world. Moreover, as we use theoretical models for the International Sex Survey, we may provide some understandings about the development and maintenance of CSBD in line with different theoretical models, and we may provide empirical evidence for or against some theoretical models, such as the impulse control disorders or addictive behaviors framework. Next, please. If we consider the potential practical implications, we can see that with the International Sex Survey, we can provide some knowledge for healthcare practitioners and healthcare professionals about people who may develop compulsive sexual behaviors, and we can provide some empirical evidence in a culturally informed manner about the potential risk factors that may lead to the development of compulsive sexual behaviors. Moreover, we may provide some information about empirically supported treatment targets and prevention targets, and we may develop innovative, for example, online interventions for compulsive sexual behavior. And lastly, from a methodological perspective, we will pre-register and make all materials publicly available, so this study may provide some blueprints for future studies in addiction, sexuality, or any other fields of research in psychology. Next, please. Next, please. So what we can see is that despite the 400 studies that were conducted on CSBD in the past few decades, our knowledge is quite limited. With the International Sex Survey, we will provide some evidence on the applicability of different scales and theoretical models of CSBD in different cultures. We will have a better understanding of CSBD in diverse populations, and this may, in the long run, lead to development and improvement of empirically supported, culturally informed early prevention and intervention programs. And if you want to participate in the International Sex Survey, or if you want to share it with your colleagues or clients or friends, you may do so by using this QR code or the ISS survey link. So thank you for your attention.
Thank you so much, Beata. And this study is also available in Polish. So if you would like to participate in the study, please check the link. And also, if there are any journalists listening to us who would like to write a little bit about the study in Polish, I would be happy to tell about it more, and you can help us promote it in Poland. And now let's listen to Ewelina Kowalska presentation about the women and sexual minorities in CSBD.
Witam Państwa serdecznie. Ja będę mówiła po polsku.
Good afternoon, ladies and gentlemen. I'm going to speak in Polish, and I wanted to talk about compulsive sexual behaviors among women and homosexual persons. At the beginning, like the previous speaker, I wanted to refer to a systematic literature review from last year. The authors have summarized the number of research in compulsive sexual disorders published in the last 25 years. They were interested in empirical publications, so they excluded PhD dissertations, non-academic journals, and also studies that have measured compulsive sexual behaviors in the context of substance dependence, affective bipolar disease, Parkinson's disease, pharmacotherapies, using dopamine agonists, and also studies concerning pedophilia and paraphilia. And the final analysis included 371 empirical articles. Like the previous speaker said, over the last decade we have seen a significant increase in the number of publications on this subject. As it turns out, 197 studies were conducted with only male participants, and only 11 were done with exclusively female participants. So you can see how big the disproportion is. In terms of sexual orientation, 140 studies did not include sexual orientation at all. 39 were done only with heterosexual individuals and 69 with sexual minorities. That means bisexual and homosexual individuals. The remaining studies were done with participation of subjects with different sexual orientations. The current knowledge about the mechanisms underlying CSBD comes from the studies that were conducted mainly with heterosexual male participants. And those studies have given us some information that the compulsive sexual behaviors affect about 3% of the general population. I'm repeating now what the previous speakers have presented already. The most commonly reported behaviors by those who seek help are the use of pornography, compulsive masturbation, anonymous and casual sexual contacts, having multiple partners, using paid sex, but there are also some less common behaviors. We also know that problematic use of pornography is the most common subtype of compulsive sexual behaviors. I also wanted to point out that this problematic use of pornography is measured not by the volume of pornography you watch, but by the quality of the use. So how much does the use of pornography affect the rest of the individual's life? We also know that being religious is also a significant factor in perceiving oneself as a person addicted to pornography. So if you are really religious, there is a higher probability that you will see yourself as somebody addicted from pornography. Another thing was presented by Professor Kraus, so I'm not gonna repeat that about the risk factors of CSBD. When I was planning my research, I was curious what it looks like among women and among homosexual persons. So first of all, I wanted to show you some of the results from our pilot study that I have conducted with homosexual men who were seeking help in relation to their symptoms of sex addictions. It is a very small sample, and let me explain why the sample is so small. These are the people who took part in a structured psychological anamnesis. So we had 14 homosexual men, and in order to show the differences, if any, I have also selected 14 heterosexual men from previous research project by Professor Gola. Those men met at least 4 out of 5 criteria of Kafka's hypersexual disorder. And they have also achieved the results above the clinical cutoff value in the questionnaires measuring addictive sexual behaviors. I'm not sure if you can read from the slides here to see what the color coding is. So on the top you can see results for heterosexual men, at the bottom you can see homosexual men, and the first behavior is the time spent watching pornography. In red you can see autoerotic behaviors, meaning masturbation, and in both groups those two are dominant behaviors. But what comes more often in the homosexual group was getting involved in casual sexual contacts. Also in this group we have a category called Other. So here our subjects reported they use, for example, dating apps to meet new people, but also they were using certain psychoactive substances during sex, so they were basically having chemsex. So now about pornography. The darker bar represents heterosexual men, the lighter bar represents homosexual men. So, as you can see, the average time of a single pornography session last month, the result is higher for homosexual men. But if we look on the average time of a pornography session at the time of the exacerbation of symptoms, the total time is much higher for heterosexual men. I have also looked at the results using the brief pornography screen. This is a very good screening tool to check for problematic pornography use. The cutoff value is 4 points. If you are above 4 points, there is a high probability you have a problem with pornography use. I have also added a control group to either of the study groups, and we can see that heterosexual men are showing very high results, much above the cutoff value. But if we look at the homosexual men, both the study group and the control group are above the cutoff value. In terms of masturbation, the number of masturbations in one day in the time of symptom exacerbation was much higher in the heterosexual group. The frequency of masturbation when watching pornography was not different between the two groups, but we saw a significant difference in the frequency of masturbation without watching pornography. Heterosexual men showed a higher result here. In terms of sexual contacts, men who were homosexual had significantly higher number of sexual partners in the previous year, and also they were showing 4 times as many attempted sexual contacts last month. So those two slides are basically confirming that the dominant sexual behaviors among men is the time spent watching pornography and masturbation. And in terms of homosexual men, also we had the behavior such as casual sexual contacts. Okay, but what about women? Last year we have published a literature review that has included the studies published over the last 5 years. The final analysis included 58 empirical articles. And what have we learned from the analysis? The severity of CSBD is lower in females as compared to males. Women declared that they watch pornography less frequently than men, and they do not feel the urge to watch pornography as often as men, and the symptoms of CSBD, including problematic pornography use, are related to features such as psychopathy, impulsiveness, but also ADHD, compulsive obsessive disorder, compulsive shopping, sexual dysfunctions, and also sexual abuse in the childhood. I have conducted research with female participants who are seeking help in relation to CSBD, and this study has included a number of various measurements from neuroimaging to psychological history taking. But since this is just a summary today, I'm going to present to you the results from psychological history that I took from a group of 25 female subjects. The women were showing results above the threshold, the cutoff value, and they have met at least 4 out of the 5 hypersexual disorder criteria defined by Kafka, and the sexual patterns in women looked a little bit more different because the most common problematic behavior in this group was getting involved in casual sexual contacts. Also, we had hyper focus on sexual thoughts, sexual fantasies, then masturbation, and only then do we have pornography. When I talked to these women as part of my study, I found that they don't feel the urge to watch pornography in order to unwind, to reduce the tension. They will masturbate to do this, and pornography is used only as some add-on, for example, to sexual contacts. We also had 4 women who admitted that they were using chat rooms and internet cameras, and we also had 6 other behaviors. The category other included dating apps, risky sexual contacts, BDSM, and orgies. Also, 15 women from that group reported they had this masturbation and pornography binging. This is interesting because when we did the previous project with heterosexual men, we also had these binges, but those were mainly pornography and masturbation binges. And heterosexual men rarely reported just masturbation binges, while women showed that behavior more often than men. So what else have I learned during history taking? That the problematic sexual behaviors are oftentimes related to the consumption of alcohol and other substances. Women also reported that they were involved in casual sexual contacts when they were looking for acceptance, when they wanted to improve their self-esteem, when they wanted to increase self-perception, when they wanted to reduce stress, when they wanted to feel they are in the center of attention. And those casual sexual contacts were related to very strong sexual arousal, even euphoria, but also with the feeling of losing the touch with reality. And most of those women, 20 out of 25, have experienced some negative experiences in the past, from broken marriages to sexual and emotional abuse. I had a case of a patient who was quite young. She was in her 20s, and she has experienced rape 3 times in her life, and now she is involved in BDSM and orgies. She feels a very strong self-destruction urge, and she also told me that she is in a relationship with her current partner because she feels he's the best sexual match for her, otherwise she would be cheating him. Also, several women admitted that when they enter a relationship, their symptoms are reduced. So the relation is like an alternative to them. So when they are in a relationship, they do not get involved in the casual sexual contacts so much. In case of CSBD, in women and minorities, we have a lot of unanswered questions. From my perspective, the future studies should be focused on 4 aspects. Primarily, the incidence of CSBD among women and non-heterosexual individuals. We should do the studies in large representative samples, preferably cross-sexual, including the gender, sexual orientation, and ethnicity. Secondly, we should verify whether the diagnostic criteria proposed in 2019 by the WHO really fit women, because the criteria will based on the studies which were dominated by heterosexual male subjects. So actually, we do not know whether those problematic behavior patterns are the same for males and females. So we should evaluate and validate the criteria for women in clinical conditions, for example, using structured history taking. The third aspect is whether the available psychometric tools validated for large heterosexual male samples are useful to measure the level of CSBD in women and non-heterosexual men. So we should validate those tools, shortly speaking. I must admit that since there are no clinical cutoff values for women, I had to base my observations on the cutoff values which were defined for men. But I think we have to evaluate those psychometric values of the tools that we have currently. And the fourth aspect came up when I analyzed this project with female participants. This was a group of over 600 women who were seeking help in relation to CSBD. I have divided them into two groups, negative for CSBD and positive for CSBD, so being below or above the cutoff value. In blue you can see the women below the cutoff value, in green you can see those above the cutoff value. Interestingly, those two bars on the left are the women seeking help currently, but who have not used psychological, psychiatric or sexuological help in relation to CSBD. And on the right you can see women who used that help before, and 66% out of those who were above the cutoff value clinically have previously used some form of help. So what has happened? Have they discontinued the therapy? If so, why did they do that? Maybe the training or the therapy was not well fitted to their needs. So I asked the question, what factors might stop women from looking for help in relation to CSBD? So we should identify the barriers which stop women from reaching for help, including cultural norms, social roles of women, religiousness, the shame and the feeling of stigmatization related to CSBD. Thank you very much for your attention.
Miałem wyciszony mikrofon. Bardzo dziękujemy, Ewelino.
My mic was muted. Thank you, Ewelina.
The speaker is Professor Joshua Groups, and he will present us his study more on congruence model, the important question.
Thank you for having me. I'm just going to wait here until I can see my slides come up. We have a bit of content to get through. So today I will be talking about the notion of moral incongruence and how morality, religious beliefs, and personal values might influence the compulsive sexual behaviors. Next slide, please. Next slide, please. And one more all the way to the end. Right, here we go. So you've seen this slide a few times before already, but this was a paper that we published a couple of years ago now on the proliferation of compulsive sexual behavior research in academic journals within psychiatry, various mental health fields, and clinical psychology, which many of us are in that discipline. As you can see, the proposal of hypersexual disorder for the DSM-5 seems to have kicked off a major uptick in this research that has only continued until the present with the inclusion of compulsive sexual behavior disorder in the ICD-11. Next slide. You can go through all of these here. So this particular diagnosis, I'm not going to go through all of the information on this particular slide, but I want to focus on this idea that we know that this was the most controversial new diagnosis in the ICD-11. It was the one that generated the most commentary from the public, which required the most kind of sustained back and forth between the development team, the focus group that developed the disorder, and kind of public stakeholders. At the center of this controversy was a lot of concern about morality and religion and how those things might influence the use of this disorder. So next slide. We've seen this criteria listed before. Dr. Krause's presentation covered it nicely, but all of the speakers have talked about this. But what I want to focus on today is this last point, that distress that is entirely related to moral judgments and disapproval about sexual impulses, urges, or behaviors is not enough to meet the requirement for the diagnosis of compulsive sexual behavior disorder. As many of you may know, this is a unique feature of this diagnosis. This is the only diagnosis in the ICD-11 that talks about morality and religion as a potential confound. Now, I want you to keep that in mind, and we're going to talk a little bit about pornography use. So if you could go next slide. Next slide. Next slide again. All right, so those previous slides were just images kind of illustrating the point that pornography use is extremely common in the developed world. We know that pornography use is one of the most common recreational activities on the internet. We also know from the previous presentations that problematic, compulsive, or excessive pornography use is likely to be one of the most commonly encountered clinical problems that therapists, psychiatrists, and psychologists are likely to see when they are diagnosing this disorder. This is especially true of heterosexual men that might think that they have compulsive sexual behavior disorder, but it's also common among other orientations, and it is quite potentially common among women as well. So we know that pornography use is quite common. We know that many people are concerned that they may have a pornography addiction. Next slide. We also know that feeling like you might have a pornography addiction is a very important mental health kind of variable to account for. We know that people that think that they are addicted to pornography are more likely to report greater psychological distress, which means more anxiety, more depression, more stress, more anger. In general, they're just experiencing more problems in their mental health. They report greater levels of addiction, greater problems in their relationships, greater lower levels of sexual satisfaction, greater problems in their religious and spiritual lives. So these people often feel like God is angry at them, or that that their religious community is disapproving of them, or that they're in trouble with other religious people, which can be a profound source of distress for clients that are extremely religious. Feeling like their religious life is having problems can create other problems as well, and reporting feelings of pornography addiction seems to predict this. We also know that people that have greater self-reported problems with pornography use also seem to have greater self-reported problems in sexual functioning. Now, this does not seem to be a direct link between pornography use itself and sexual functioning. It's rather the perception that one has a problem. So someone that uses a great deal of pornography and feels fine about it and does not feel addicted often reports better sexual functioning or greater sexual functioning. But people that report feeling addicted to pornography do report problems in sexual functioning. Both men and women, we're talking about issues of erectile functioning, as well as sexual responsiveness and things like that. Next slide. We also know that over time, self-reported problems with addiction to pornography predict greater psychological stress, greater religious and spiritual distress, greater pornography-related problems in the future. But they don't actually predict more pornography use. There's actually clearly here somewhat of a discrepancy that we see between self-reported pornography addiction and self-reported pornography use, where the self-reported addiction is driving a lot of problems in their mental health, but the use is somewhat independent. Next slide. Now, this leads me to the question, generally speaking, of what might predict someone feeling addicted to pornography, what might lead someone to think that they are addicted to pornography. And what we know from a wide variety of studies, now these are all taken in the US, but in the United States population, what we've consistently seen is that more religious people, people that think pornography is morally wrong, people that identify as religious and not as an atheist, people that come from religious families, and people that report moral incongruence are more likely to report that they are addicted to pornography. Now, I want to focus on that last piece of moral incongruence and what leads to feelings of moral incongruence. So if we could go to the next slide. Moral incongruence, and you want to advance kind of slowly through this here, is this idea that we might, some people, generally speaking, people want to see an alignment between their ideal self and their actual self. They want to see that their beliefs regarding pornography and their behaviors regarding pornography are the same. So if you think porn is wrong, you generally would think, oh, I should not use pornography. Keep advancing here. But for many people, we see that these don't necessarily line up. We actually see that there's a discrepancy here, which leads to experiences of dissonance. Those should actually be separated, but that's separate here. So we see this dissonance between the two, where people are using pornography even when they do not think that it is appropriate to use pornography. This is something that we call moral incongruence. Essentially, it's the notion that your beliefs about pornography and your pornography behaviors do not line up. Next slide. We can go to the next slide here. All right, so we actually laid out this particular model very systematically in a review and meta-analysis that was a Target article in the journal Archives of Sexual Behavior, which is one of the larger sexual health journals in the field, where we put forth a general theory of how moral incongruence could lead to people saying they have problems with pornography use. Next slide. Go ahead and advance through this whole one, right? So this is basically the model that we laid out. We laid out a two-pathway model that essentially describes different ways by which someone might develop feelings of addiction to pornography. Pathway one is the traditional dysregulation pathway. People, for a variety of reasons, start using pornography too much, too frequently, or excessively. They become out of control, if you will, which leads to a dysregulation pathway leading to self-perceived addiction to pornography and all sorts of psychological distress. But some people experience moral disapproval of pornography, which, when it interacts with pornography use, leads to feelings of moral incongruence, which leads to those same feelings of addiction and distress. So essentially two separate pathways. Some people are actually dysregulated, and that's why they think they're addicted. Some people are just feeling very morally incongruent, and that's why they're feeling addicted. And then the two of these pathways could go together, where we don't lay it out in this diagram, but some people might both be dysregulated and feel morally incongruent. So they're both out of control and they feel like they're violating their morals. That would be pathway 3, or just kind of the combined pathway. Next slide, please. Now, we meta-analyzed these findings here in the literature and of what had been published previously, and what we pretty consistently found was that in community samples, that means not in clinical treatment seeking samples, but in the general population across a couple of countries, moral incongruence, or the experience of moral disapproval among people that were still using pornography, was the strongest predictor of self-perceived pornography-related problems or pornography addiction. It was actually almost twice as a powerful predictor as actual pornography use itself, suggesting that in these general community samples, moral incongruence was the most robust predictor of perceived addiction to pornography or self-reported problems. Next slide. Now, we took this particular model, we have extended it to nationally representative samples in the United States, where we found the exact same pattern of results. I'm not going to go through all of those findings, but we did extend it and see again that moral incongruence was a very powerful predictor of self-reported addiction to pornography, as was pornography use frequency, being a man and being younger. So young men that use pornography frequently while feeling morally incongruent about it, those are kind of the most at risk for feeling addicted to pornography. Next slide. This particular model was also tested in the Polish population by Karol Lowczuk and Maciej Szkola, really leading the project there. I was fortunate to be able to contribute to this as well. If you could go to the next slide, we'll go over those results. We found a similar pattern, although the associations were a little bit different. And what I mean by that is we did see this clear pathway of dysregulation, where some people seem to be having issues with avoidant coping or other issues in their life leading to frequent pornography use, and then which led to self-reported problems with pornography use. We also clearly saw that some people, due to more religious values, had more moral disapproval of pornography, which led to more moral incongruence related distress, which led to problematic pornography use. That's the right side of the slide here, where it's a clear pathway there. Now, again, the most powerful predictor of self-reported addiction to pornography or problematic use was the frequency of pornography use. But this moral disapproval and moral incongruence related distress pathway was quite significant as well, demonstrating again that moral incongruence seems to influence whether or not people think they have an addiction to pornography. We've also, we go ahead to the next slide here. Continue to develop this model in further nationally representative samples in the United States, but instead of just looking at does moral disapproval of pornography predict self-reported addiction, we actually looked at a moderation effect, or the interaction of moral disapproval and self-reported addiction. In this particular sample, we looked at how religious people were, and we saw how that interacted with pornography use frequency. We could go to the next slide. And we saw a clear association where if you look at those slopes on the right side of your screen, you can see people that were very unreligious, the far left of those kind of 5 panels. The links between pornography viewing frequency and self-reported addiction to pornography were quite low. But as we got more religious, as that slope moves across those panels to the right, you see that slope getting stronger and stronger. It's a more steep slope showing a stronger association, which shows us pretty clearly that more religious people interpret their pornography use as addictive more readily. Essentially, the link between use and addiction is much stronger the more religious you are, suggesting that for many religious people, using pornography while religious is taken as a sign of addiction. We can go to the next slide. We also extended this across a number of samples in the United States, looking at moral disapproval itself. We took a number of samples of the U.S. population. We go to the next slide here. We found consistently that if we measured pornography use in hours per day and self-reported addiction to pornography, we saw the same moderating effect, where that blue line are people that disapprove a lot, that orange line are people that disapprove only a little, and that green line is the average. We see clear differences in the relationship, where people that disapprove a lot report a much stronger link between the amount of pornography consumed per day and the extent to which they feel addicted. Next slide. In another nationally representative sample of the United States, we saw this same pornography viewing frequency, that same moderation happening again, where morally disapproving individuals, that blue line, people that disapproved a lot, were likely to report a strong relationship between viewing frequency and self-reported problems, whereas people that did not disapprove very much only showed a very weak relationship, which is that orange line. So again, a clear interaction where there's a multiplying effect, where moral disapproval multiplies the effect of pornography viewing frequency on the likelihood that you will report feeling addicted. Next slide. We demonstrated that yet again in another sample. That's our third sample there. The same pattern of findings again. We can advance another slide here. We also decided to test this longitudinally in the US. So if we want to advance 2 slides here, where we measured pornography use, and go ahead, there's some animations on the screen, some red boxes to highlight. You'll see those boxes in red there that are worth noting there. Specifically, what we see is that moral disapproval and self-perceived pornography-related problems, or moral disapproval and reported addiction to pornography, are extremely closely related to each other over time. Over the course of 1 year, basically what we found was it clustered very, very strongly together, to the extent that it was almost hard to differentiate between these variables, suggesting that in general population, non-clinical treatment-seeking samples, people that are saying that they feel addicted to pornography might just be dealing with excessive feelings of guilt or shame related to their moral disapproval of pornography use. So next slide, and we'll go through that one. So this basically leads us to a few clear conclusions that we've derived from this program of research over the years. The first of these is that various religions are often quite concerned with regulation of pleasure-seeking impulses. This is not a particularly novel finding. What we know is that religious communities often have a lot to say on how people are allowed to do things to enjoy themselves. This is extremely relevant to sexuality. Almost every major world religion has very specific proscriptions on how sexuality may be partaken in, how people might enjoy it, and what they might do with it. Most often this means a very firm regulation on what types of sexual behaviors are appropriate or not, and typically religious groups prohibit the use of pornography even though their adherents do use pornography quite frequently. When we see these pleasure-seeking impulses, these sexual drives, and religious beliefs in conflict, moral incongruence is likely, which in turn influences whether or not someone thinks they have a sexual addiction. This is obviously in those diagnostic criteria that I mentioned before, but we need to be aware that some people might experience moral incongruence so severe that they think that they have a disorder, even if they don't technically have such a disorder. Now, next slide. I want to talk about what this leaves as far as the big questions left in the field. So in my opinion, we have three major questions related to moral incongruence that are absolutely essential. The first is whether or not moral incongruence is indeed unique to self-reported addiction to pornography or to compulsive sexual behavior disorder. A really great study taken in the Polish population by Karol Lowczuk and colleagues last year found that moral disapproval of various addictive behaviors such as internet use, social media use, also predicted feelings of addiction to those behaviors, which strongly suggests that these feelings of moral incongruence may not be unique to self-reported addiction to pornography or to compulsive sexual behavior. Because of this, we do need to understand more whether or not this morality piece is unique to compulsive sexual behavior disorder. Secondly, we absolutely need to understand if it matters outside of a Christian faith. You'll notice that the studies that I referenced before were either taken in the US or in Poland. As I'm sure most of you are aware, Poland as a country has a very large Catholic population. The US has a very large Protestant evangelical population, which is a subset of Protestantism. But essentially, these are two countries that have extremely religious populaces. We need to know if non-Christian countries are exhibiting these same patterns, if other faith groups are distributing it. Essentially, going back to what Dr. Bolta talked about earlier, we need better research that crosses cultural borders. And finally, we need to know if religion and morality affect clinical judgments. And what I mean by that is there are a couple of studies, only two that I'm aware of, maybe three, that suggest that religious therapists are more likely to diagnose sex addiction or hypersexual behavior. Now, we do not know about compulsive sexual behavior disorder yet, but if the past it tells us anything about this, it does suggest that religious therapists might be more likely to diagnose patients with this disorder because of the therapist, the clinician, the psychiatrist's own beliefs. Essentially, it's letting the personal beliefs of the professional dictate the diagnostic process rather than the experiences of the patient. And this is a particularly concerning thing that we really need to know the answer to. Now, how do we get these answers? If we go through the next slide, I think that there's a few future directions we can go that can really show us how to answer these questions. The first is we need true epidemiological studies. We absolutely need population-level studies that are probability sampling methods with clinician-based interviews where we can truly understand the prevalence of compulsive sexual behavior disorder across cultural settings. These need to be internationally collaborative where possible. The International Sex Survey, which you've already heard about a couple of times, is a huge step in the right direction here. We absolutely need things like that to study how moral incongruence plays out across compulsive sexual behavior disorder across cultures. But we also do need epidemiological studies across cultures as well. And we need more research that studies how clinicians are using the diagnosis. There's a lot of effort that's been placed on validating this diagnosis, proving that the diagnosis is useful, finding ways to connect patients with the help that they need, finding people that qualify for this diagnosis, but we need better research on how clinicians themselves use the diagnosis. Because anytime we are applying a diagnosis to aspects of sexual behavior, it's possible that we could stigmatize or otherwise discriminate against people of non-majoritarian or non-majority sexual orientations or practices. So we need to better understand how clinicians are using this diagnosis to make sure that it's being applied appropriately. Thank you, and I believe that's the last of my slides.
Thank you so much, Josh. It was very, very extensive and great deep presentation of your moral incongruence model and big questions which we need to answer in the future. Okay, we have one more presentation. We are running out of time. I'm afraid we won't have time for discussion, but let's try to go briefly through the last presentation. I don't see my slides yet. Okay, please advance. Here I would like to answer the question, what do we need to learn to be able to treat CSBD more effectively? And the first question I identified as a big question is, which treatment approaches are really effective? What do we know about it? Next slide. So right now in the literature we have a lot of case studies. Sometimes they are case series, like this paper by me and Mark Potenza, where we have few subjects who've been treated with paroxetine, for example. There are similar studies showing the effects of naltrexone and other substances. And they just show that for some cases of CSPD, some kinds of medication or psychological treatment works, but we know that case studies are not a systematic way to study certain problems. The next slide, please. So the next step are open label studies. And during the last few years, actually last 3 years, there have been a few first open label studies. So in this kind of studies, we have a larger samples of people with CSBD who have been treated in a certain way. And for example, there is such a study showing that naltrexone may work, and it was conducted on 20 men with CSBD. Another study with psychological treatment from Paula Hall group showing that this particular way of treatment, reducing stress, may be helpful for CSBD patients. This was conducted on a bigger sample of over 100 people. But here we still don't know, is it more effective than placebo? Is it more effective than other kinds of treatments? For whom does it work? For whom it doesn't? So it doesn't answer all the questions. Next slide, please. So we need studies with good control groups, and this is more difficult. And here there are some examples of such studies regarding CSBD. For example, our group conducted a study on the mindfulness-based relapse prevention program in CSBD, and here as a control group we had just a waiting group. So people with CSBD who were waiting for treatment while other group was in the treatment. So we were comparing these two groups. The group led by Beata recently presented results of the online intervention study. It was much more, at least at the beginning of the treatment, and then the control group was also the waiting group. So in this type of studies, we can learn a little bit more because there is some control groups, but we still don't learn a lot. We don't know how does it work compared to other interventions, compared to placebo. And in currently available studies with such control groups, the samples are not big enough to learn about the variability of the treatment outcomes. Next slide, please. And you can advance it. So here is an example of double-blind randomized control trial with placebo. This is our study where we had two active substances, naltrexone, paroxetine, and placebo, and longitudinal design. But unfortunately, as you see, this wasn't a large study. However, it was double-blind randomized, and there was a placebo group. So we can learn a little bit more how the treatment works compared to placebo. There is no effect of researchers who know what do they administer as a treatment. but the sample is relatively small. It's 25, 27 people per group. So we still don't have really available large double-blind randomized trials either with pharmaceutical or psychological treatment in case of CSBD. So that would be one of the next steps we would need to approach. Next slide, please. So the second big question is for whom and why those treatments works. Once we will have more studies on treatments, we will question. And here we can see few possible problems. Next slide, please. For example, in the study by Paula Hall, we can see that only 36 people out of 119 who participated in the study participated in the 6-month follow-up. So actually, we know very little about the remaining 80% of this population who took part in this study. And based on those who participated in the follow-ups, we know that the treatment worked only for some of them. Majority of them experienced reduction of the CSBD symptoms, but only 58% of them experienced a reduction of stress or other comorbid symptoms. And we know that 30% of people who participated in the follow-ups didn't experience significant improvement. Next slide, please. In the study by Saward and his group on naltrexone, actually the group of UC Jokinen, we can see that, okay, naltrexone worked for a majority of people in this group, but there are some people for whom it didn't work. There was no improvement after 4 weeks of such a treatment. But when we look at the details of the method, we also see that a lot of subjects were excluded from the study because they had comorbid disorders. For example, they were using alcohol, or they had some other symptoms which didn't allow participate in the study. So we don't know how this treatment would work for more generalized population with those comorbidities. So it shows us like few examples of potential problems. Yeah, whom do we include to our studies, and also who is excluded because of dropouts in our final assessments. Next slide, please. Here are the results of a study by Beata on the online platform Hands Off. And here we can see there was a waiting list, and there was a self-help intervention online. And we can see that in the follow-up there was only 10% of subjects participating in the follow-up with the intervention. A little bit more with the waiting list because they wanted to participate in the intervention later on. But still, we don't know what happened with 90% of people who dropped out from the intervention. Was it helpful for them in the early stages, or maybe it wasn't helpful? Why? What was the characteristic of those people? This is something what we don't know because we have a very limited amount of data and number of studies so far. So next slide, please. The third big question is how to personalize treatment. So once we will be able to answer the question which modalities may work and for whom, because we will have a larger samples, then we will need to figure out why it works for some of the subjects, why it doesn't work for others, and how to personalize it so it will be effective, so we can pick the effective treatment for everyone or for majority of people with CSBD. Next slide, please. And here are our results of our brain study. We replicated these results across multiple different groups. And here basically we show that subjects have increased reactivity of certain parts of the brain related to dopamine release, dopaminergic circuits. And this increased reactivity is visible when we compare their reaction to erotic cues compared to healthy controls. Those parts of brain are just more reactive. And this is, next slide, please. this is highly related. This was replicated also by other groups across multiple different countries and research teams. So we can say that, oh, this is like a signature of CSBD, and it resembles other addictions, something really general. Next slide, please. And we see that this pattern of brain activity is related to the symptoms of CSBD, like number of masturbations, time spent on pornography use, and the screening symptoms. But when we look at the details on this first graph on the left, the black dots are patients with CSBD, the white squares are control subjects. Then, and on the vertical axis, we have this brain reactivity for erotic stimuli versus monetary stimuli, so other types of reward. So we could assume that, okay, if this is something what is well replicated, which is a signature of CSBD, then it should be a pattern which is representative for majority of all of the CSBD patients. But as you can see, there's a lot of black squares, CSBD patients, who have this very high reactivity, and they are more reactive for erotic stimuli than other stimuli. But there's also equal number of patients who don't present such a pattern. Yeah, and why? Why we have such a variability? When? What does it mean? How those two groups differ? Yeah. Maybe one treatment will be more effective for one group who has this pattern more pronounced, and another for those who doesn't. Yeah. So we don't know the answer for this question. Next slide, please. So here, this is the idea that basically when we look at the brain patterns, something which is, very measurable, very objective, we see a lot of variabilities, and we can distinguish potentially few different subtypes of those patterns. And we still don't understand how they are related to symptoms, how they will be related to the treatment, which treatment will be more effective for one subtypes, which for others. And there's also a huge layer of psychological effects and cultural effects, as you can hear in the presentation of Evelina, Beata, or Josh, for whom which kind of treatment will be better for people who have moral incongruence patterns, and for which treatment will be effective for those who don't. How would it look like in the different cultures? How would it look like in the different genders, in the different groups regarding to the sexual orientation, and so on. So let's move forward. So basically, we need to understand what CSBD really is, what are the variabilities of CSBD, what are the different mechanisms and different underlying patterns, both on the neuronal and psychological levels and cultural levels. And based on that, we need to figure out how to diagnose those differences between different subjects, different potential subgroups, and then how to pick the efficient, individualized, targeted treatment for all of them. This is something which is still ahead of us, something which we need to address in the future studies. Next slide, please. And one way to do it is by using big data. So having big data from representative samples collected across different social groups, different countries, or huge groups of people with CSBD, but with different sexual orientation, different genders, different patterns of development of CSBD, either through dysregulation or through more incongruence. This is something what we need to have. We need to collect this data, and based on that, we can start using all the wonders of machine learning methods or other advanced methods of data analysis. We can try to cluster subject, try to find patterns, and then maybe we will be able, if we will do a lot of studies with different treatment modalities, maybe we will be able to also figure out which treatment will work best for each type of subjects, each subgroup of subjects. So this is the future. And next slide, please. Just to summarize, to figure out which treatment approaches are effective, we need to have a lot of randomized clinical trials with placebo and different treatment modalities. To answer the question for whom and why those treatment approaches work, we need large inclusive samples and good tracking of dropouts. And to answer the question how to personalize treatments, we need big data and advanced analysis of this data. So there's a lot of work ahead of us, but it looks pretty exciting. So that's it. Thank you so much. And thank you for attending this session. I would like to also thank all the speakers for accepting the invitation for this session. I hope we will continue discussion on how to advance those studies in the near future. And I would like to thank the organizer of this conference of giving us this opportunity to meet here and also ask those big questions. It's very important for our field of studies in compulsive sexual behavior disorder. Bardzo dziękuję wszystkim organizatorom za taką możliwość. No i mam nadzieję, że to się przyczyni też do rozwoju właśnie tej działki badań. Jeśli mamy czas na pytania, nie wiem, czy mamy, to zapraszam. Jeśli nie, to życzę Państwu
I'm not
dobrego
sure
wieczoru.
if we have any time for questions. Are there questions? Are there any questions that cannot wait? We might have one question. No questions? After all this intense day, we are probably very tired. So thank you, Professor Gola, for preparing this session, because Professor Gola organized this panel on his own. He invited our speakers. Thank you for being with us, even if it's online only. Thanks to you for being here until such a late hour. I invite you all to dinner and see you tomorrow.